Okay. Okay. Well, thank you, ladies, for coming. My name is Dr. Leanne Greenberg with Annie's Apothecary, and today I'll be going over an integrative approach to chronic pain. This is the third in our series. Our first one was Hashimoto's, which you can find on our YouTube channel, and then also last month, Dr. Rachel Krajewski did integrative approach to fibromyalgia. So I'm not really going to focus on fibromyalgia or the Hashimoto's component, but just looking at overall other things to do for chronic pain. So there's a picture of our pharmacy and me and Rachel. So either one of us can answer questions on any of the topics, and there's our contact information. Okay, so medical disclaimer. This is just information that we provide, just a very kind of beginning. For practitioners, we definitely encourage you to continue doing your research and see what's appropriate for your patients. And then as a patient, make sure you ask your practitioner if it's the right therapy for you. So learning objectives, we're just going to compare the conventional and alternative treatment for chronic pain. The biggest one I want to go over is understand the mechanism of action of low-dose naltrexone, and then how using very low-dose naltrexone and ultra-low-dose naltrexone to help treat chronic pain, especially with patients that are on opioids. And then we'll also identify the benefits. Oh, I already said that. See, I didn't even have to read it. Okay, so the science behind pain in general is the overactivity of our pain-sensing nerves. Okay, so our central nervous system becomes more sensitive to pain over time, so that's what causes chronic pain. It has less of an ability to suppress those pain signals, kind of like inflammation. So if we have a small amount of inflammation, it continues to increase to where everything causes inflammation, kind of like allergies. You get oversensitized, same thing with pain. You have systemic inflammation and nerve inflammation or neuroinflammation. The glia are the support and the immune cells of the CNS. Glia are activated due to inflammation, so a lot of disease states are caused from inflammation. I'm not going to really go over it in this particular presentation, but a lot of the foods that we eat can cause inflammation. So definitely when we're looking at chronic pain, you want to look at sources of inflammation, not just treating inflammation. So conventional treatment of pain, obviously pain medications, right? So that's treating the symptom. Muscle relaxants can be used for muscle pain. Antidepressants are typically used for nerve pain or neuropathy. You can use anxiety medications to help calm and relax. Pain is it's a big stressor to the body, so it causes a lot of different imbalances in our body. Anti-inflammatory, so that's one that helps with pain, but it's actually targeting the inflammation if it has an inflammatory component. Stretching obviously can help. Exercise can sometimes alleviate pain. And then there's a lot of different complementary therapies. So massage, medical massage is typically the ones rather than just the Swedish, feel-good massage, but you could do medical massage where you get deep tissue, acupuncture, yoga, a lot of different things that can help with chronic pain. Sleep is extremely important as well. It kind of goes hand in hand. People who are in pain don't sleep. People who don't sleep have more sensitivity to the pain because their body is not rejuvenating at night. So we definitely want to get you to sleep. And then obviously psychological support. Very big mental component in a lot of chronic disease states, especially chronic pain. So having psychological support is extremely important. So let's look at some of the alternative medicine approaches. I'll go into more detail on a couple of these, but basically stabilizing the patient, right? Enhancing mitochondrial function, so we can use that through supplementation, including magnesium. I'll go into more depth with magnesium. L-carnitine helps with, it's an amino acid, but that helps with nerve regeneration, and then CoQ10 and glutathione also help support nerve regeneration as well. Balancing the hormones is extremely important. We find, especially in women with progesterone and fibromyalgia, that was something that Rachel talked about last month. Progesterone is actually anti-inflammatory as well. So there's a reason why women are most afflicted with fibromyalgia, which is kind of a diagnosis of process of elimination diagnosis. You can't really test somebody for a fibromyalgia. But we have seen improvements in fibromyalgia when you balance the hormones and put progesterone on. So that's just one example. Low-dose naltrexone is something I'll discuss today as well, looking at assisting the inflammation component and then the immune system in autoimmune disorders. And then there's some just hodgepodge unique etiologies that could be causing pain. So heavy metal toxicity can cause nerve pain. Leaky gut and food sensitivities is something like I discussed. Come on in, you can have a seat. Okay. Let me get you a handout real quick. There you go. You're welcome. My mom is one who had mercury in her mouth, and she was having kind of overall fatigue and chronic pain. You have to actually go to an environmental dentist to get mercury removed, because whenever they heat it up to the drill extraction, it vaporizes and can make people worse. So you definitely have to go to an environmental dentist, and if anybody needs that afterwards, I can make a recommendation to one in San Antonio. Excellent. My mom went to him. It was great. She had like 5 amalgams removed, and so that heavy metal toxicity can be a contributor to chronic pain. The leaky gut and food sensitivities, like I said, we can actually test that here at the pharmacy to see what your sensitivities are. This isn't a histamine response like you have an allergy to an ingredient or a food. It's foods that are causing inflammation or creating an IgG and an immune complex response. So that's something we can do at the pharmacy to eliminate the foods that are actually causing inflammation, which could be leading to whatever type of chronic pain is going on. And then obviously adjust treatment as needed as you go through this process. So let's talk about magnesium. Magnesium is wonderful. I think magnesium should be in every single person's regimen, whether you have pain or not. I use it in my children. I take magnesium. It's used for so many different things, but especially with people with pain or people who can't sleep. It's a natural muscle relaxant by blocking the calcium channels in our muscles, which causes contraction, so it helps relax our smooth muscles. Epsom salt is magnesium, so there's a cheap way to absorb magnesium. You can take an Epsom salt bath, especially if you're in acute pain. But I traditionally recommend magnesium all the time. It's also what's called an NMDA receptor blocker, which that may not mean anything to you, but ketamine, a lot of people know ketamine is a very potent pain reliever, has the exact same mechanism as magnesium, just a lot more potent. So you can use magnesium because NMDA it helps, how do I put this? NMDA is a transmitter that makes your body sensitive to the pain and makes you feel the pain. So magnesium blocks that. So that's how it helps with pain desensitization. And that's the way ketamine works as well. So there are actually different forms of magnesium, and the form is really, really important on how you're using the magnesium. So we carry several different types of magnesium based upon what I want to use it for. So magnesium citrate, you can buy that. It usually comes like in a green bottle. That's a really good laxative because it's not absorbed very well. Okay, it'll just go straight through your system. Magnesium glycinate, however, is the one that I have people use all the time to actually get into your tissues, because that will help with the muscle tension. That will help replace magnesium deficiencies in your body. Magnesium threonate, however, crosses the blood-brain barrier and gets into the brain. So it helps with anxiety and calming in the brain. Can also help with focus, can help the stress response. So we actually have a product, and I use this one in my children. It has a mixture of the threonate and the glycinate. Both of my kids my younger ones are 9 and 12. They're both athletes, and during select season, they're training kind of late at night. One of them is a gymnast. She trains till 8:30. She's only 9 years old. She's got to get up early the next morning, but her body is not ready to go to sleep, and her mind is racing. And so we use a product that it's just in powder form, put it in water, and it helps calm her body and her brain so she can go to sleep and she's not up till 10 o'clock at night. Works wonderful. So with magnesium, and then they also do just magnesium baseline all the time, but on workout days, I have her do the one that gets in her brain also. The people often ask me, well, how much magnesium do I take? Well, everybody's different. It just depends on how deficient you are. We usually say start with about 100 milligrams orally of the glycinate component, and then increase every couple days until you get loose stools. Because remember what I said about the magnesium citrate, unabsorbed magnesium is a great laxative. So that's kind of your marker of, okay, my receptors have enough magnesium, and then cut back. So some people may take 400 or 500 milligrams of magnesium glycinate a day. So everybody's different. Okay, so the next one is oxytocin. So I don't know if anybody's heard of oxytocin, but it's used for a lot of different things. Typically, it can be used for fibromyalgia, for increasing sexual desire in women. It's considered the love hormone. We've used it in a nasal spray sometimes for depression, for orgasm in women, to get our brains to the same place that the guys are physically. But recently there's actually been some studies that it helps with pain and stress. So most of the studies have been on animals right now, but there are some promising results that it can be used in pain. But it makes sense to me because it kind of goes hand in hand. Depression and pain, those kind of you see together a lot of times. Which one comes first, I don't know. But the oxytocin can help with that because it releases endorphins and it can help reduce pain. So it'll be exciting to see more information come out on that. Here's the dosing, usually in a nasal spray. We have a couple patients that have autism that we've used the oxytocin in, and depression. So we're constantly trying to get more feedback from our patients as we're making recommendations to build our clinical judgment personally with our patients. But there are some really good studies out there. Okay, so the next one is CBD. So a lot of people have been coming to us about CBD. So this is just a real quick, short and dirty on the endocannabinoid system. So just like receptors for our hormones, we have endocannabinoid receptors in our body. There's two different types. There's CB1, which is the green, and that's scattered throughout the body, and that's more the central nervous system. And then there's CB2, which is the immune cells, gastrointestinal tract, and the peripheral nervous system, which is external, in the blue. So yes, our body makes our own cannabinoids, but whenever you have a disease, you're able to take CBD to help counteract some of those symptoms. So the ECS symptom helps regulate sleep, appetite, pain, pleasure, cognition, memory, mood, movement, and immune function. So when people come to us, they like, well, I want to take CBD for this particular ailment, right? Whenever we tell people, same thing kind of like with the magnesium, it helps so many different body parts. Other symptoms may go away that you didn't initially think it would help, and the one that you wanted it for, it may not help. So same thing with dosing too. Start low, go up. CBD is extremely popular these days, especially in Texas. There's a lot of regulation on CBD. In Texas, you can have less than 0.3% THC. What we choose to carry is 0 THC. I've been carrying this one even before Texas passed that law on the hemp-derived CBD because I haven't seen that you would need that from a therapeutic perspective. We're mainly using it for pain, inflammation, helping people sleep, calm, relax, anxiety, especially when you use it sublingually, it gets into the system really, really quickly. So this is the particular brand we carry. And then topical too. The topical ones are really good for like arthritis and chronic pain where there is inflammation because this particular company puts other things in there besides just CBD. They put some essential oils in there, some arnica, some B6, and it's just a much better product than just CBD alone. I don't think there's any one thing out there that's the cure-all, and CBD is not it either. So it's just a portion. Hi, welcome. No, you're fine. And if you want to go, you know where that room is, grab a chair. Sure. Thank you. Okay, so let's go to low-dose naltrexone. So naltrexone is actually an FDA-approved drug that was approved a long time ago, back in the 80s, for heroin addiction at a 50 milligram dose. There's a copy of the slides right there. Awesome. And there's been a lot of different studies on it at the 50 to the 200 milligram dosage range for addiction. It's an opioid antagonist, meaning it blocks the opioid receptors, and so it prevents opioids from working, right? So typically if there's an overdose, that's when you would want to remove those opioids off of the receptors so you can not have it cause that action anymore. Well, for some reason, at lower doses, we're finding it works completely differently. So here's kind of a timeline of some other things. 2005, there's some Yale studies, and Contrave is a FDA-approved drug that is being used for weight loss. And it's a combination of lower than the 50 milligram dose naltrexone with bupropion, which is an antidepressant. So that's an interesting combination. Also, there's Oxytocin is a clinical trial. Phase 3 clinical trials actually had to discontinue because there was a high dropout rate. I couldn't find why there was a high dropout rate. It wasn't from side effects or anything of that nature. It was just a higher dropout rate than what they normally see in a clinical trial. But it did show some benefits. They combined 1 microgram, that's what the U stands for, or if it's MCG. So 1 microgram, tiny, tiny, tiny amount of naltrexone with oxycodone. So why was a drug company doing that type of research? Well, they were able to look and see that you could get lower doses of oxycodone and increase the efficacy of it without the side effects and the addiction component by using the naltrexone. So let's kind of look at that mechanism of action. So in low doses from the 1 to the 5 milligram, naltrexone reduces that glial inflammatory response. Remember at the beginning I was talking about glia cells and how those were activated by inflammation. So naltrexone actually helps reduce that inflammatory response. It upregulates, meaning increases, opioid signaling. And it helps us increase, endogenous means our body makes it, endorphins, which is the pain-relieving chemicals that our body makes. So at low doses, naltrexone has a completely opposite effect than at 50 milligram dose. It's also neuroprotective by inhibiting the glial activation, which helps in that pain pathway, right? Decreases inflammation and excitatory chemicals. So that's all the chemical stuff, right? But it doesn't have that same effect at higher doses, which is interesting. And I kind of relate that to hormones. More isn't better in hormones, and more isn't better in naltrexone depending upon how you're using it as well. So is it tolerable? So we always look at side effects with something, right? So this was a survey results from a friend of mine that did a survey in his pharmacy with low-dose naltrexone. There was average age of about 51. About 83% of them were female and 17% of them were male. And this was their dosing, kind of what dosing they were on. 87% of the people had no side effects, period, whatsoever. Some of them had some insomnia, meaning you couldn't go to sleep. Some of them had vivid dreams, and then some of them had headache. So the vivid dreams, typically you take low-dose naltrexone in the evening or at bedtime. We attribute the vivid dreams to that endorphin release. And even some of the patients that we have here, if we move their LDN dose to the morning time, then that takes care of it. Or we might need to back off on the dose, let their body adjust to it, and then increase back up. So there's always ways to affect the side effects. And you can see in their particular survey, they had resolution 4 days, 2 days on average. It's just usually typically when you bump up to the next dose. So this is just a kind of a graphical representation of what I already went over. So basically it's well tolerated, is what it tells me. The low dose, the LDN Trust, LDNresearchtrust.org has a ton of different studies that low-dose naltrexone has been used in, not just in chronic pain, but a lot of autoimmune disorders, because it helps target that inflammatory response, like I discussed. This is just a smattering of different drug disease states that there's either studies or it has been seen beneficial use in. So what are the advantages and disadvantages of low-dose naltrexone? So the advantages are it's a very low cost compared to some of the traditional treatment options, especially like with neuropathy, and you have a lot of brand name drugs. And a lot of times not just one drug treats the pain. A lot of times you have to be on several different drugs, so that adds up. Very minimal side effects. I haven't seen any study that said there's an abuse potential So that's really positive, especially when you're dealing with chronic pain. And it is effective for quite a few patients. Some of the disadvantages is, lack of proper dosage finding experiments. So there's no, kind of like the magnesium, there's no one set dose for an indication. And healthcare providers have a hard time with that. They want, well, what do I use for this? What do I use for that? What do I use for this? What dose do I use for this particular person? Well, you start low and you go up, just like you do with CBD, just like you do with magnesium, because everybody's different. So the same holds true with low-dose naltrexone. And it's not recognized by a lot of insurance companies because it's for off-label uses. And you do have to get it compounded because, like I said, commercially available is only 50 milligram. So let's look at this real quick. Just overall, there's a review of therapeutic utilization. This came out of Dartmouth Medical School. They reviewed over 900 published articles, and they summarized the top 85 articles relating LDN for chronic pain. These were some of the pain conditions that they looked at. Looking at opioid taper and mental health, like the depression, neuropathies, joint pain, and fibromyalgia. CRPS is chronic regional pain syndrome. That's another difficult diagnosis to treat for patients. So here's kind of the dosing that we were talking about, right? So 50 to 100, it blocks the opioids, and it's used for alcohol and opioid abuse. What's considered low dose, really low dose, is like a tenth of this, right? 1 to 5 milligrams, and this is what it's used for, all those inflammatory pain disorders. So now we have very low dose, may have the same mechanism, but you can add it on to people who are trying to get off of, say, methadone, or you do cross-tapering, or say they're already on an opioid to treat their chronic pain. You wouldn't want to start them out higher because we're going to block that pain the pain-relieving pathway, right? So you have to start out much, much lower, microdosing rather than low dosing, and cross-titrate. Because whenever you do it low, it helps with the pain relieving also, and you might be able to decrease their pain medication, okay? Okay, so ultra low dose naltrexone. Remember I was talking about that oxycodone, that Oxytrex clinical trial? This particular review, one of the studies they found was using oxycodone with 2 micrograms of naltrexone daily. It proved to be the best modality of the available study treatment. So that seemed to work the best in their review. They reported fewer opioid-related adverse effects, such as constipation, somnolence, tiredness, and pruritus, which is the itching. And then a low percentage of patients affected by the opioid withdrawal effects following active treatment cessation. So when they got them off, so something happened chemically at the receptor level once you added that very, very tiny, tiny amount of naltrexone. So more studies need to come out. Obviously, it would be interesting to see, read more about the clinical trials of why people dropped out, but I couldn't find any information on that. So here's a dosing protocol for pain, and once again, this is just an example. Every person's different. If you're not on opioids, then you could start out at like 1.5 milligram capsule, and then you increase up just like you would magnesium. Typically, we tell people, give it a good 6 months. If you don't see an improvement, then you're not going to see an improvement. But typically, people notice an improvement, especially in the titration, between 2 to 4 weeks. What's critically important is don't miss the mark. I had a patient who she was doing really, really well. She's a Hashimoto's patient, doing really, really well on 1.5 milligrams. Her practitioner doubled her dose to 3, and she felt overall pain again. So I was like, go back to what you know. You were feeling really, really good on 1.5. It was just too big of a jump. And so I think we ended up getting her to 2, and she's good. She's great on 2, but that small of a dosage change for that particular patient made a difference. So you don't want to titrate too fast and increase too fast. So here's just some options on the, if someone's on opioids, like I said, go even lower. So that's what they're terming very low dose naltrexone. So 100 micrograms daily and increase every week. You would never increase quicker than a week at a time. And this is if they're on short-acting opioids. A lot of people who have chronic pain are on controlled release, so it's letting it out throughout the whole day. You would want to start even lower, so 1 microgram a day, and then slowly increase that. And as you're increasing that, work on tapering down the opioids that the patient is on. So lots of education. That's kind of the moral of the story. I know very, very little of what's out there. There is so much information, but we know where to look, which is what's most important. So anytime a patient comes to us with a particular issue or a symptom, we look, well, is it inflammatory derived? Would low-dose naltrexone work? Are there studies? What's the dosing that has been utilized as a starting point? And then same thing with the practitioner. They just call us. Hey, I have this patient. They're on this or they're on that. And we just work with everybody to get to the best results for that patient. And that's it. I'm going to turn this off and I will take questions. I know it's a lot of information.